Dear ESTS members and webinar attendees, it is 6 p.m. Central European Time, so we are going to start with this webinar. After a very successful first ESTS webinar on ERAS in thoracic surgery was launched in November last year, we had an immediate success of around 1,000 attendees. I would like to welcome all of you to a new series of webinars that will be launched by ESTS. Right now, we are about 50 attendees and 200 people were subscribing for this evening. My name is Leyn de Piepere. I am a general thoracic surgeon at the University Hospitals of Leuven in Belgium. I am a member of the Learning Affairs Committee, and I will try to be your host and moderator on most of the monthly webinars. I will try to make it as practical as possible, but please send me suggestions for improvement, as I'm not familiar with this task and the software yet. It is the first where we are going to work with this software, so please give me any suggestions, they are welcome. CME accreditation will be asked upon for the upcoming webinars, but the accreditation will probably not be provided for the first 3 webinars. But let me introduce you to Professor Paul de Leyn. He is the head of the Department of Thoracic Surgery in Leuven. He is responsible for the lung cancer care program and author of hundreds of publications. His clinical research is focused on mediastinal staging, and he's the author of the last editions of the ESTS guidelines on pre- and perioperative mediastinal lymph node staging in non-small cell lung cancer. So please, Professor de Leyn, the stage is yours.
Oh, good evening on behalf of myself. So I will try to show you, we have to see if everything is working. You see the slides, Leyn?
We can perfectly see your slides, yes.
Okay, thank you very much. So I will try to guide you through the pre- and perioperative guidelines of the ESTS. So I'm the chairman of the Department of Thoracic Surgery, and there you see my co-people who are working with me, and Dr. de Piepere is one of our staff thoracic surgeons. So we will start with 2 cases, then I will try to guide you through the preoperative mediastinal staging and restaging guidelines. Why do we stage the mediastinum and how do we do it? We made some guidelines in 2007. We have done an update in 2014, and in November we will have the first meeting for the update to 2019. I will tell you some few words on intraoperative mediastinal staging, and finally, hopefully we have some good questions and discussions. So this is the first case I would like to present you. It's a 65-year-old female. She has an adenocarcinoma in the right upper lobe, proven by EBUS miniprobe. She has perfect pulmonary function. There are no distant metastases. And when we look at the PET-CT, we see on CT scan enlarged hilar and mediastinal lymph nodes. So 10 right, 4 right, 7 and subcarinal. And on FDG, there is uptake in the right paratracheal lymph nodes. So for staging, she is clinical T2A, N2, single staging on PET-CT M0. So here you see the CT scan. So this shows you the imaging. So you have a large lymph node position 4 right, which is PET positive. And then is my question, in your practice, would you do invasive mediastinal staging? The answer A is it's not indicated. We will give induction therapy anyway, and then surgery if there is response. B, it's not indicated. It's single station disease. I will do resection, right upper lobectomy with nodal dissection. Or you do EBUS, EOS, fine needle aspiration. If it is negative, you do video mediastinoscopy. Or answer D, you do video mediastinoscopy.
Okay, so I'll try to make this poll working. Yes, it's working because there's already some people voting. So it is in your sidebar at the right side under polls. You have questions, polls, and people. So there you can vote what you are going to do yourself in your clinical practice. There's already one question, and there was a question about is UV Do we know anything about the SUV uptake?
The SUV is quite high. It's 7.
Okay.
So high SUV uptake in the tumor.
Okay, so we already had more than 15 people voting. We will wait a little bit more. And then, yeah, it gets quite interesting. I'm not sure if you can also see, Professor Leyn, if you can also see the voting.
Yes, I see them. C.
So right now there's A, B, C, D. Answer C gets 60% of the answers right now. So EBUS, and if negative, video mediastinoscopy, and the second most chosen is video mediastinoscopy in 21%. But it still is changing.
We still proceed a little bit with the voting, Leyn, yes?
It's what you want, yes.
Okay.
I think now it's not
changing anymore.
So we have 2/3 EBUS, and if negative, video mediastinoscopy. The second choice is video mediastinoscopy, and the not indicated ones are, let's say, rare.
Okay, it's a perfect answer. So I think we can stop the seminar. Now, as I will try to explain you, the correct answer is C. EBUS is here minimally invasive, less invasive than mediastinoscopy. But if it is negative, in a PET positive and suspicious lymph node, there should be done a mediastinoscopy. Very good answer. So we go to the second case.
Okay.
It's a female patient, 64 years.
You first have to share the video.
Okay. One moment, please. Sorry. Wait. Okay. You see the slides again?
I can see them, yes.
Okay, so for the first one, the correct answer was EBUS, and then if negative, mediastinoscopy. So this is the second case, a female of 64 years old. So she has a peripheral adenocarcinoma in the left upper lobe. It's 3 centimeters. The PET-CT is positive on the tumor. We have an SUV of 7, so it's quite high. It's positive on a hilar lymph node, so position 10. So it's not position 5 or 6, but it's really in the hilum. And it's negative on the mediastinal lymph node. So no enlarged PET-positive lymph nodes in the mediastinum. So for clinical staging, it's clinical T1C, N1, positive hilar lymph node, M0. And I have, well, the same type of question. Would you do invasive mediastinal staging? A, it's not indicated. I will do resection with nodal dissection. B, I would do EBUS, EUS, and if negative, mediastinoscopy. C, I would do mediastinoscopy. Or D, I would start with VETS with exploration of station 5 and 6.
Okay, maybe you can go back to the case a little bit.
Yes.
One slide back, yes.
So I don't have any imaging, but it's a patient, peripheral adenocarcinoma left upper lobe with a PET-positive hilar lymph node. The mediastinum is negative on PET, and there are no enlarged mediastinal lymph nodes.
Okay, people are voting.
Once for the question.
Well, the questions can be seen at the sidebar also.
So I have the images on, Leyn, if you just tell me what the answers are at a certain point.
Okay, so right now we have 50% answer A, not indicated.
Mm-hmm.
We have 25% EBUS, EUS, if negative, video mediastinoscopy. The third answer is only 8%. And the fourth answer is 25%. So we have almost 50% first answer, and the second and fourth are divided, let's say, around 20-25%.
Okay, so it's a quite.
For answer 1.
You would choose for answer 1.
The most people are choosing for answer 1.
Most would choose for answer 1. Okay, so, well, I think it's a little bit dependent on your strategy, but we know that patients with PET-positive hilar lymph nodes have about 25 to 30% chance of having positive mediastinal lymph nodes. So I will come back later to it. And as I will show later, EBUS is not very sensitive in detecting these lymph nodes because they are not enlarged, and mediastinoscopy is the best to find these positive mediastinal lymph nodes. So I think if you go for optimal staging, the correct answer is C. It's of course a bit dependent on your strategy. If you would say I would resect immediately the tumor, but you will have 25 to 30% unforeseen N2 disease, but we come back later to this.
That's interesting. So here we can learn a lot. The first case was quite easy. The second case is only 7% who chose for video mediastinoscopy.
Yeah.
So I think we're ready for your talk.
Okay, thank you. So why is mediastinal staging important? Because we know that in patients with lung cancer who have no metastasis, about 1/3 of the patients have positive mediastinal disease. And okay, the current treatment strategy is that for patients with no lymph nodes or only hilar lymph nodes, you go for surgery and adjuvant chemotherapy and or immunotherapy. For N2 disease, there is a lot of discussion, surgical multimodality versus chemoradiotherapy, and patients with multiple N2 or bulky N2 or N3 disease usually are treated with chemoradiotherapy. As you know, the Pacific trial now shows that these patients may benefit from also adjuvant immunotherapy. We should know that N2 disease is very heterogeneous. I will not go too far on this, but you have really radiological normal sized lymph nodes, and then you have the bulky lymph nodes, and you have unforeseen N2 disease. Unforeseen N2 disease are N2 nodes that you find despite optimal mediastinal staging. And this is a very old slide, and I will not go too deep in it because we all know that staging has been changed by PET-CT and better CT scanners. But when you look in the 80s and in the 90s, they tried to operate on patients with positive mediastinal lymph nodes. And if you look at the group of Toronto, this was a selected group of patients. So they excluded the extracapsular disease, they excluded the high paratracheal lymph nodes, and you see a low complete resectability and a poor 5-year survival. So really resecting on patients with positive mediastinal lymph nodes that you know before the operation is probably not so beneficial because most of these patients will have micrometastasis or distant metastasis, but you cannot detect it at the time. This slide just shows you the incidence of unforeseen N2 disease, and you see the better you stage the patients, like in the group from Serfolio, routine use of PET-CT, and then EBUS and mediastinoscopy, you see the rate of unforeseen N2 is going down 7%, and you see the 5-year survival is going up also with the adjuvant chemotherapy. So we should try to stage the patients as good as possible, and if you then find unforeseen N2 disease, you resect them, you give them adjuvant therapy, and you get a 5-year survival of 35%. There is a lot of discussion in the surgical literature that with these results, and these are the results published by Rush in 2007, and you see here for patients with N2 disease, you get a 5-year survival of 22%. But we should not forget these are patients with unforeseen N2 disease. These are patients who had optimal staging, and then you find unexpected positive lymph nodes, and you can find a 5-year survival of 22%. But if you operate on patients with PET-positive lesions in the mediastinum, you cannot compare with this group of patients. So you should be careful by saying that all patients with single nodal PET-positive mediastinal nodal disease should be operated. And that's the reason why we need to stage as optimal as possible, and then depending on the staging, treat your patients, maybe with induction chemo, induction immuno in the future, or maybe with primary surgery if it's only one single nodal station, intracapsular disease. These are the different ways of staging. You have imaging, you get tissue by invasive surgical staging, or you have, let's say, the non-surgical invasive staging, which also provide tissue like EBUS, EUS. And what do you have to choose? We know cervical mediastinoscopy, it has a very low morbidity. There are almost no contraindications except for patients with permanent tracheostomy. You can do it as an outpatient procedure, and it has a high negative predictive value. But of course, there is some morbidity, left recurrent nerve, sometimes a wound infection, and if there is a bleeding, it can be quite heavy. These are the regions which you can reach by cervical mediastinoscopy, and if you do mediastinoscopy, you should really try to biopsy or remove all these lymph node stations, and you can get very far in the subcarinal region, I would say, about until this level you can get. But of course,
Professor Leyn, you say biopsy or remove. There's a question here, biopsy or remove, question mark?
I will come back later to it. So okay. You have the VAMLA and the TEMLA, and okay, patients are better staged, but we have to agree that there is some morbidity, and I will come back later to it. There's some left recurrent nerve palsy with VAMLA, and regarding the ESTS guidelines, we say you have to try to biopsy as much as possible, but we don't advocate to do a real VAMLA because in not so experienced centers, it could give some morbidity. But I will come back later to it. And then, of course, you have the non-invasive, the invasive non-surgical staging like EBUS, EUS, who have much lower morbidity, but maybe not the same accuracy. So these are the regions which you can reach by EBUS. It's about the same as with mediastinoscopy. And with EUS, it's mainly very good for the left side, left paratracheal. You can get to the subcarinal area, the ligaments, and as you know, you can also biopsy the left adrenal gland. Level 5 and 6 nodes, you can only reach by extended mediastinoscopy or anterior mediastinotomy, but nowadays most centers will use video-assisted thoracoscopy because you see the phrenic nerve. These are often not that bulky lymph nodes, and it's much easier and safer to do it by video-assisted thoracoscopy. So in 2007, we made the ESTS guidelines for preoperative lymph node staging. You see the different quarters. And at that time, it was a quite easy scheme. So you do a PET or a PET-CT. If it is negative, you can go to surgical treatment unless the A, in central tumors with large lymph nodes on CT, or with PET-positive N1 disease. In these circumstances, you have to do mediastinoscopy. Or your PET-CT is negative, you have PET-negative or small lymph nodes, enlarged lymph nodes or PET-positive lymph nodes. You need tissue confirmation. In 2007, this was mediastinoscopy and a dotted line for EBUS, EUS. If it is positive, you can go to multimodality treatment. If EBUS is negative, you have to do mediastinoscopy because the negative predictive value of mediastinoscopy is much higher than with EBUS. And in 2014, we did a revision of these guidelines. And as I told you in the beginning, in November 2018, we will have the first meeting to make revised guidelines because things are changing, new technology, and also treatment strategy is changing. So this is how we worked. It was approved by the ESTS. We had several meetings and we had a consensus, or tried to get a consensus. It was presented at the yearly meeting. The paper was put on the website for input by all the members, and then finally it was submitted and accepted for publication. Just to show you some slides, you recognize Professor Rami Porta and Professor Vachil. And then we had an airport meeting in Zurich and an airport meeting in Brussels, and after 3 meetings, we had some consensus. So the paper is out and you can read it, but we recommend really to biopsy if you do mediastinoscopy, but also if you do EBUS, to biopsy at least 2 ipsilateral, 1 contralateral, and the subcarinal lymph nodes. And of course, if positive, if present, you need to biopsy much more lymph nodes. So these were the guidelines in 2007. What has changed? And okay, this was a meta-analysis published in 2011. And I have to say this is the 6th edition. So you have to be careful with T2 because a tumor up to 5-6 centimeters was still a T2. But you see for small tumors, your negative predictive value for mediastinal staging is very good, 94%. But for larger tumors, and especially adenocarcinoma, with a high FDG uptake, the negative predictive value was much lower. And then we have this prospective study from Hospital Clinic Barcelona, who evaluated the ESTS guidelines in 153 patients. And you see central tumors were excluded. And then you see once again for T1 small tumors, a very good negative predictive value. But for larger tumors, the value dropped to 85%. What about centrally located tumors? Well, this is a publication from 2007. But you see, when a tumor is centrally located, even in small tumors, 0 to 2 centimeters, you see a quite high percentage of positive lymph nodes. So in about 1/5 of the patients, although PET and CT was negative on the mediastinum, you had positive occult N2 disease. And this is for N1 disease, and I will show you some recent publications because this is a quite older publication from Japan without the PETs. So patients who had small lymph nodes in the mediastinum, but a higher positive lymph nodes on CT, the prevalence for N2 was 30%. So, and this is the reason why we changed the guidelines on the left side. If you have no lymph nodes and the lesion is peripheral and smaller than 3 centimeters, you can go immediately to surgery. If your tumor is larger than 3 centimeters, and especially in an adenocarcinoma, or if you have N1 disease or a central tumor, you should try to get tissue confirmation, either by EBUS or video mediastinoscopy. And I will come back later to this because there are some new data showing us what we should do. And this was also one of the questions in the cases. If you have positive lymph nodes, the first thing to do is EBUS EUS. If it is positive, you can go to multimodality treatment, and this is not a dotted line anymore. There is prospective data here. If it is negative, you still need to do a mediastinoscopy, and what we suggest is that you do a video mediastinoscopy. So this was an important question, positive or large lymph nodes, what to do. I will go a little bit faster over it. This was a prospective multi-center study. Excuse me, you see the centers who participated. And these were patients who needed invasive staging because they had or PET positive lymph nodes or large lymph nodes or central tumors. And the endpoint was the sensitivity to detect N2 and N3 disease. So patients were randomized either to surgical staging or to first endoscopic staging, and if negative, followed by surgical staging. And then you see the sensitivity to find N2 disease was in the group with surgical staging only 80%. And if you do first endoscopic staging and then surgical staging, as you could expect, but it's proved now 94%. So the first step is to do EBUS-EUS. It's less invasive. It gives you an advantage when you have to do restaging and you detect more positive lymph nodes. So this is a busy slide, but just to show you, if you do fine needle aspiration, and these are data from the paper of 2014, you still have quite some false negatives. So even with good fine needle aspiration, it's not that good as if you do mediastinoscopy. And this is, of course, this is a view of a positive lymph node, but you see a lot of necrosis, and you all know these patients, and you really have to biopsy the vital tumor to really prove, or sometimes you only have part of the lymph node which is positive. This is the reason why mediastinoscopy will always be better than EBUS-EUS. So we first have to do EBUS, and if it is negative and you have a suspicious lymph node, you have to do mediastinoscopy. We did some literature search on mediastinoscopy, video mediastinoscopy. I will go further over it, but you see things much better. We can make movies and show each other what we can do, and especially the bimanual dissection, if you want to do VAMLA, is of course superior over normal mediastinoscopy. So you see the left recurrent nerve. It's difficult to see it with normal mediastinoscopy. If you look at studies who compared mediastinoscopy to video mediastinoscopy, you would expect better lymph node staging, higher accuracy, but it is not like that. A bit surprising, but if you put the literature together, there is no real difference, but everybody of us feel that you see things better and it's safer with video mediastinoscopy. So in the ESTS guidelines 2014, we recommend video mediastinoscopy over conventional mediastinoscopy because you can teach, you see it better, and you get some standardization of technique. And then, as we discussed already, you can of course do more. You can remove all the lymph nodes through the mediastinoscope, which is called VAMLA, or you can do, and this was developed by Dr. Zielinski and Dr. Kutzal, the transcervical mediastinal lymphadenectomy. It's a combination of open and endoscopic techniques. And of course, your sensitivity and your negative predictive value is better. This is for sure. You remove all the lymph nodes. But if you look in the literature, and these are highly experienced centers, the recurrent nerve palsy is a problem. And if you have a recurrent nerve and then you need lung surgery, it's a problem for the surgery, after the surgery, aspiration. So if you can avoid it, it's better to avoid it. So it's highly accurate, but there is morbidity, and it's performed in very selected experienced centers, but we cannot recommend it for routine use. I go very fast over restaging. So PET-CT is unfortunately in restaging less accurate than in baseline staging, and you really need histology to prove that there is downstaging, because mainly these patients will treat from surgery after multimodality treatment. You can do remediastinoscopy, excuse me. You can do remediastinoscopy in some centers, very good experiences. We did a prospective study and we had poor results, and also EBUS for restaging is not optimal. The problem with remediastinoscopy is a lot of fibrosis, and it's related how extensive your first mediastinoscopy was. If it was very extensive, orophamla, it's almost impossible to go in the subcarinal area again. And it's not the induction treatment, but it's rather the previous mediastinoscopy who made it difficult, because this is a study from Didier Lardinois. So the sensitivity and the accuracy when patients were no induction, and this is induction chemo in patients who never had a mediastinoscopy. So, and then you see that the accuracy is good. The problems are the remediastinoscopy. So this is something which is now done in most centers. Baseline, you have the PET-CT, you prove N2 disease, you give the induction chemo or chemo radio, and then you use a PET-CT to stage the body and to look at the tumor response. Is there a drop in SUV? It's not so good for the lymph nodes, but you use your first mediastinoscopy for your lymph nodes results. And then you can see, should I go for surgery? Is there a role for surgery? Or is it maybe better to give radiotherapy? So I'm going to show you a few things. We are going to make a revision in 2019. And as I told you, if you have on PET-CT N1 disease, you have about 20 to 30% unforeseen N2 disease. And in the guidelines of 2014, we said you could do or endoscopic staging or video mediastinoscopy. Very fast, 2 prospective studies. This is Professor Doom's prospective multi-center study. And you see, if you do in these patients N1, but small lymph nodes on CT, PET negative in the mediastinum, and you do EBUS, EOS, you see a poor sensitivity, 0.38%. And then we have the study that Herbert de Calloway did in the same group of patients, mediastinoscopy in clinical N1 patients. And you see, I have just to look at the slides here, yeah, it was 73%. So it's a huge difference. So in patients with clinical N1 disease and small lymph nodes, PET negative in the mediastinum, you better do mediastinoscopy than EBUS. One word about intraoperative staging. I think nothing has changed there. We made the guidelines in 2006. You remove all the mediastinal tissue. There's not only the lymph nodes, but the fatty tissue in the mediastinum, in the hilum, intra and interlobar. You put them in separate files and you send them to pathology. So these are the lymph node stations you take on the right side and on the left side. Just to show you, this is the region for the right side, and the posterior part is the pericardium of the ascending aorta, and then the subcarinal lymph nodes and the lymph nodes in the ligament. This is an intraoperative view after induction, and it's open surgery. So this is posteriorly, this is anteriorly, this is the middle lobe, this is the lower lobe. It's after right upper lobectomy. This is the caval vein. This is the trachea. This is the
vagal nerve.
The vagal nerve, and it's this region which you need to take. We took here the azygous vein. It's not necessary but the lymph node was fixed to the azygous vein, and this is the reason why we divided the azygous vein. But it's of course not necessary in routine nodal dissection. This was on the left side. Why should you do it? Is there a better survival? Probably not. It's probably optimal staging, and this is a prospective multi-institutional study done in the States, T1, T2, and 0. But you see, there was an extensive intraoperative lymph node sampling, You see all the lymph nodes they took on the right side, on the left side. They had to be negative on frozen section, and then they were randomized to nodal sampling or nodal dissection. But you see quite extensive sampling, and they had to be negative on frozen section. And then you see, well, there was no difference in local regional or in overall survival. So if the lymph nodes are negative, for sure, it has no impact on local regional recurrence if they are negative. If they are positive, I think you should take them. But of course, if they are positive and you know it, you can give adjuvant chemotherapy or immunotherapy, and this group of patients really benefit from the adjuvant therapy. So I would like to conclude. So for staging, well, at least if you do EBUS or if you do mediastinoscopy, you should take 4 right, 4 left, and 7. And of course, if present, you have to take more biopsies. You don't have to take the hilar lymph nodes. You can go below the azygous vein, this is 10 right. You should not do it routinely, only on indication when it will change your policy. So if you have a peripheral small tumor, you can definitely omit invasive staging. In central tumors or in one disease, you should perform mediastinoscopy, and it's better than EBUS, EOS. And if you have larger tumors, especially adenocarcinoma with a high SUV, you should consider invasive staging. We can discuss on whether it's really indicated, but if you believe in induction treatment, you definitely have to do it. So if you have a PET positive lymph node, which is suspicious, and EBUS is negative, you should do surgical staging, because surgical staging has a better negative predictive value. We recommend to do video-assisted mediastinoscopy, and as I told you, we are planning to do an update of these guidelines in 2018. We have made a working group, and the first meeting is planned in November. So by this, I would like to conclude, and thank you very much. And I'm, of course, open for questions and discussions.
Okay. Thank you very much. So everyone can ask questions right now. The questions can be asked in the sidebar at the right side. And we will try to make this as interactive as possible. If you have questions which we can put in a poll, we will also try to do this. Maybe I'll start with the first question. There is in the guidelines central tumor, but there's always doubt about what is the definition of a central tumor. Can you comment on that, please?
Yeah, that's a very good question. And well, what is central? For some people, it's when it's visible on bronchoscopy. For other ones, it's the inner third of the lung. And I have to say, there is probably no real good definition. And Dr. De Calloway, who is also one of the staff members for his PhD, looked at the different definitions and looked at the prediction for N2 disease. And I must say, it was rather disappointing. So in his retrospective study, in patients with central tumors, we found no real high incidence of N2 disease. So, but I think this needs to be confirmed in more studies. But based on his work, which were over 700 retrospective patients, patients with a central tumor by either definition, where we did invasive staging or lymph node dissection, the rate of positive mediastinal nodes was not as high as we found in the literature. So that's a point we need to discuss further. But it's a very good question.
Okay. Another question came in. I think the question is as follows: the number of metastatic lymph nodes, I think it's that, the number of metastatic lymph nodes resected, does that matter for survival? So
yeah, Well, so you have two things. You have the number of lymph node stations, and this is indeed predictive. If you have a patient with multi-level, let's say 4 right, 2 right, and an interlobar lymph node, this is predictive for survival. The more lymph node stations, the lower the survival. I know the literature a little bit of the esophagus, of breast, of colon. There you have the total number of positive lymph nodes on the number of lymph nodes removed, and that's not really proven in lung cancer. I think, yeah, probably it's not so easy to say how do they count them, but the number of lymph node stations, definitely for sure. Yeah.
Okay. And another question. If there is no experience with extended video mediastinoscopy,
yeah.
So there's an example here: 3 centimeter left upper lobe tumor, PET negative. When we go for VATS sampling 5-6, do you suggest to rely on rapid biopsy or to go straight forward for the lobectomy?
Yeah. So I think another good question. So it's a little bit different if you have a left upper lobe tumor, 3 centimeters, and there are no lymph nodes in the hilum and in the mediastinum, or even if there are some enlarged lymph nodes in the orthopulmonary window. I think most centers would go for immediate surgery and lymph node dissection, because there has been some evidence, it's old literature, that even with positive lymph nodes in the AP window, you have a quite good survival. So I would not do an extended mediastinoscopy. You can put in, of course, and most of you will do it by VATS, the resection. So sure to look, of course, at the lymph nodes, but if they are positive and it's only they're positive, I think you should proceed with resection and adjuvant chemotherapy.
Okay, that's clear. A lot of questions are coming in. So the next one. What should we do with the T3 and 0?
And it's T3 due to chest wall invasion, or the tumor large, or
that's not mentioned, but we can discuss both, I guess.
I can say if it is a T3 due to the tumor diameter, I think it's best to do mediastinal staging. If it is a small tumor invading, yeah, even if PET-CT is negative. Yeah.
Okay.
If it is a small tumor invading the chest wall, or even a pancreas tumor, I would say I would not do mediastinal staging.
Okay.
So if you can do primary resection, do it. If you need to give induction chemoradiation for the T factor, you give the induction chemoradiation.
And the third type will be even more difficult, I think. Two lesions in one lobe.
2 lesions in one lobe, I would not do mediastinal staging for this. It's a satellite lesion, and then it can be positive, it can be negative. I think they also have a better prognosis than an ordinary T3. So I would not do it.
Then, and let's say completely other question. Is there any place for direct surgery in a single in-2 station confirmed by invasive staging?
Well, that's a good question. And I think, and if you are sure that it is single station, but that is the problem. I think if you have a PET positive one, well, this would be a very good randomized study to have PET positive single station lymph nodes, proven by EBUS that it is the only lymph node station, and then randomized between induction or immediate surgery and adjuvant chemotherapy. And I think in small lymph nodes, which are not bulky, and I mean lymph nodes smaller than 2 centimeters, which are very much delineated from the trachea, and you think it's not extracapsular, and you have a good EBUS, and you can prove that it is single station, there may be a room for immediate surgery, but I think this would be a very good prospective study.
Okay. What would be your personal preference? If you have this, do you go for mediastinoscopy first to prove this, or?
I would say if I have a tumor with a single station N2 disease, I have a quite high chance that I have micrometastasis. I would like to prove that the lymph node is positive by EBUS, and then first get my induction chemo and then the surgery. Because if you first get surgery, it takes at least 3 weeks, 4 weeks before you can get your adjuvant therapy. Your immune system is a little bit down. So I rather get you need adjuvant chemotherapy anyway, or immunotherapy. I rather get it before the surgery if I hopefully have no micrometastasis or only very small ones. So my preference is first the induction and then the surgery.
Okay. I see a lot of cases coming in, so I'll try to skip this right now, just to have some general subjects. Another question: can we agree on this statement? In patients with a negative mediastinum on PET-CT, indication to stage the mediastinum. Excuse me. In patients with a negative mediastinum on PET-CT, but indication to stage the mediastinum because of the size of the tumor in one disease, we choose for mediastinoscopy without EBUS as staging modality.
Yeah, well, I think these are the questions which I tried to answer in the last part, and which has now been proven by the study of Herbert de Calloway and Christophe Dons, both multi-center prospective studies. If you have small lymph nodes in the mediastinum, but you have N1 disease on PET, then the sensitivity of EBUS is about 30-35%, and of mediastinoscopy, it's about 75-80%. So in these patients, we should do mediastinoscopy instead of EBUS, and probably this will be in the new guidelines, but this is new information from 2017.
Another interesting question here from a surgeon from Ukraine. Our hospital does not have a PET-CT. We only have CT and video-assisted mediastinoscopy. Can we do our end-staging by video-assisted mediastinoscopy?
Yeah, I think that's for sure. That's the way we always did it before. So I think, well, one of the big advantages of PET-CT is, of course, that you pick up distant metastases in the brain. Not in the brain, sorry, PET-CT is not optimal for the brain, but I mean in the bone. So, but if you don't have PET-CT, then you have to do video mediastinoscopy, let's say, in almost every case, except a peripheral squamous cell carcinoma smaller than 3 centimeters. And this is like we did it before PET-CT. And I think if you do it like this, you can do optimal mediastinal staging. But you miss the distant staging, which is at least about 10% of metastasis that you miss by not having PET-CT.
Okay. And another question coming back to your answers of the last question. If you have a single station in 2 proven with EBUS, should we go to induction or do mediastinoscopy to exclude the multi-station in 2? But there I thought you were more going to the multimodal treatment then, huh?
Well, that's my personal opinion, but I think this would be a very good international study. If you say we have single level, we prove it by EBUS or mediastinoscopy, even better, of course. And then we randomize between immediate surgery with adjuvant chemotherapy or induction chemo and then surgery. Personally, I think if you have N2 disease, in many cases you have distant metastasis and you will benefit to get your chemo or your immunotherapy as soon as possible. But that's my personal view. I think, but we cannot conclude from the study from RUSH, the International Association, which is a database, that you can say the 5-year survival of N2 is 22%. So I operate on them. This was unforeseen N2. These are patients who were staged, and then intraoperative you find pathological proven N2. But this is something completely different than to operate immediately on PET positive proven histological N2 disease. This is something different.
Okay, now we come back to the unforeseen N2. Another question. You have done nice staging. It's completely negative. you do your lobectomy at the left side, and during the lobectomy, you find an unforeseen in station 5. Do you proceed with your lobectomy, or do you go to neoadjuvant therapy?
No, I think the principle is if you have done proper staging and you find intraoperative mediastinal nodal disease, if you can resect it, and usually you can resect it, but if you can resect it without having to offer the caval vein and everything, but if you can resect it by just lung resection, you do your resection and give adjuvant chemotherapy. If you find bulky N2, which is not completely resectable because you have positive tissue because it's encapsulated in the trachea or something like that, that's something different. And then maybe you better close and give chemoradio. But to close, give induction and operate again, I would not do it. But usually you can resect it and you give adjuvant chemo.
Okay. Let's see for some other questions. How and when do you perform staging of a left upper lobe non-small cell lung carcinoma? So what do you think about the prognosis of these patients, especially in single station lymph node involvement in the aortopulmonary area?
Yeah. So there is old literature from Patterson, and it's from 75, 80. Patterson, who was also in Toronto, that patients with positive mediastinal nodes in position 5 and 6 have a better prognosis than roughly unforeseen, and it's about 35%, because you could say it's like maybe an N1 lymph node instead of N2. So as I told you, if we have a left upper lobe tumor with single station small PET positive lymph node in the AP window, we will do mediastinoscopy to exclude N2 disease and other stations, and we'll go to surgery and adjuvant chemotherapy. So I think one PET positive lymph node, but if of course a lymph node of 4 centimeters, but if it's 1 centimeter, 1.5, you should do mediastinal staging, exclude multi-level or N3 disease, and then do your VATS lobectomy with nodal dissection and adjuvant chemotherapy. And your 5-year survival will be probably 40–45%.
Okay. Let's see for some other questions. If you have a left upper lobe peripheral 3 centimeter adenocarcinoma with an SUV uptake of 7 on PET, the mediastinum is negative, and then the mediastinoscopy, but I don't know why we would do a mediastinoscopy. The mediastinoscopy revealed metastatic lymph node in station R4. What would be your plan? But I mean,
so 4 right is positive.
4 right is positive, but then
Well, I think the plan would be to give chemoradiation if it's possible to have it all in one field. So I don't think there is a role for surgery in these cases with proven N3 disease, because it has gone over the subcarinal and the paratracheal zone. So I think if it's feasible to have it in one radiation field, concurrent chemoradiation in these cases with proven N3 disease. And just be sure that 4 right was not 4 left. So it's not a mix-up by the pathology, but if it's 4 right, which is possible, chemoradio.
Well, when I'm reading the case, it looks like the PET was negative, so I don't know why they did a mediastinoscopy anyway. But it's a strange. It's a strange case. I think this is most of the questions we had. We had, let's say, about 80 attendees, which is quite good for the first time. I don't know if any other questions come up, then you can still ask them. Otherwise, I think we will end this session. It's about an hour right now. I will just make some advertisements for the upcoming ones. And I'll try to share you. This one's So now I think you can see the upcoming ESTS webinars. You see this will be monthly. The next one will be November 19th on sublobar resections, indications, and techniques, with the guest speaker being Dominique Ossot from Paris. And then we go on till May 19 for this year. Hopefully this will be a success, and I hope that the next or the upcoming ones that we can also get some CME accreditation for that. Let's see if there are still some other questions. Another one was regarding the use of PET in the evaluation of the response to the induction treatment. Have you some experience with the use of the PRECIST qualitative criteria? They seem to be very good at differentiating the flagellistic rather than the neoplastic tissue.
I must say no. I'm sorry, I don't have. We use PET in the evaluation. Mm-hmm. What I know is that it's not as good as in primary staging. It's mainly a problem on the lymph nodes. In the primary tumor, the drop of SUV is predictive for survival and for response. But I don't exactly know. I know the RECIST criteria, but I don't know. So I think I would say on the lymph nodes, it's not very good. I found it quite sensitive. So if the PET scan is still positive, it's usually positive, but the negative predictive value is often poor, which I mean you can have a lymph node which is more fibrotic. It's negative on PET-CT after induction, but there is still a viable tumor in it. So the negative predictive value on the lymph nodes is small, is low, but on the tumor, the drop of SUV is predictive for response treatment and also survival. I hope this answers your question.
Okay, I think with this this question we can close this session. We just had 1 hour of talks. I see some congratulations coming in for you, Professor Leyn. So thank you for sharing this presentation with us. Mm-hmm. I'm looking forward to the next presentation, and I hope you too. If you have any questions or any other remarks, you can always send them to me as moderator, and then by email, and then we try to work on this in the following ones. I just have some polls for you that I'm going to fire right now. Did you like this format of webinar? Will you, in your opinion, was there enough interaction or not? Just to know what we can do the next time. And will you attend the next webinar or not? If you can just answer this once, that would be great. Then we know what to work on for next time. Okay, thank you, everyone. I'll let this just for the polls for another 2 minutes, and then we will close up.
Thank you very much. It was very interesting.
Okay, so it looks like it is quite successful. The first answers I get in. So hope to see you next time. Bye.